How do we need to reform the healthcare system to adequately care for the frail and aged? That's the topic Dr. Joanne Lynn addressed during her presentation at Conversations at the Crossroads, the 2013 Joan Berkeley Bioethics Symposium. Dr. Lynn is a geriatrician, hospice physician, health services researcher, quality improvement advisor, and policy advocate. She currently leads the Altarum Institute's Center on Elder Care and Advanced Illness. Her work has focused on shaping American healthcare so that every person can live comfortably and meaningfully through serious illness and disability in the last years of life, and do so at a sustainable cost to the community. Dr. Lynn, thank you for being willing to join us on the Bioethics channel. Welcome. I want to start our conversation today dealing with something that should be ancient history. The 20-year-old Robert Wood Johnson study entitled Support that looked at how we die in America. Why, 20 years later, is this something that we're still talking about and that's still affecting what we're doing?
Yeah. Well, it was a big study. It was 5 hospitals around the country and about 10,000 patients who were at very high risk of dying. And no one has been willing to put the funding in to do anything like that since. So the studies we have since are either of Medicare claims or they're of relatively small populations. You know, this hospital, this hospice program, maybe a network of 4 or 5, but we just haven't been interested enough to get beyond that. Can you think of any other arena where we would use 20-year-old data in education, in housing, in diseases? Of course not. You know, we would have replaced it with much more up-to-date data. But in this arena, there just hasn't been the push.
What did we learn from the support study? And for you, what were the most important findings that we should have taken to heart?
Well, people keep thinking that it's about decision making, and we do have to improve decision making and helping people to be effective in making their own decisions. But we also have to change the care system. The care system was built around rescuing people from bad stuff, so rescuing from injuries, rescuing from heart attacks, rescuing from strokes, whatever. It was never built around the idea that people were going to stay sick. And now most of us will hit a period where we stay sick. I mean, we may be thriving and living well, but we need help with getting to the bathroom, or we need help with getting our cooking done, or we have lost our eyesight, or we have joints that won't work. And most of us will live for now on the order of 2 to 3 years at least of needing someone else's help on an everyday basis. And we never built a care system around that assumption. We somehow thought that kind of families would do it, or that it wouldn't really arise. I've talked to so many people, even leadership people, who believe, kind of without examining it, that somehow death would just happen. And not that they would live for a long time, propped up by medicine and propped up by various other things that would keep them alive, but with substantial disability at the end of life. So we had this sort of sense that people were dying over just a couple of months. And if we just brought hospice in, all would be well. But we never really looked at the long-term care system, the services and supports, the housing supports. And now that we're going to triple the number of people who are old, sick, and frail together, as the boomers all grow old together, we're going to have to step back and say, well, so what is the efficient system to help people live reasonably well at a time when they can't be working and where they didn't have enough children and they didn't have enough savings? You know, are we going to be willing to walk out on people and let them go without food and housing? Or are we going to rally and put together a care system that works? And the time is ripe, because the boomers have just started hitting 65. They're still pretty hale and hearty. It's when you start hitting 80 and 85 that you start getting large numbers of people who are disabled. So we've got this little span of time in here where we could put good systems in place. And if we don't, we will just learn to walk out. We will learn to say, well, it's just their fault.
Which is a scary thought, given
Isn't it?
You know, how
and
many
so much of it isn't anybody's fault. I mean, somebody whose best job in their whole life was a minimum wage job doesn't have the savings to handle long-term care. Somebody who's been a school teacher all their life and maybe has made $60,000, $70,000 a year as they retire, they may have enough for their savings for their routine care, but what then if they have a terrible stroke and they live for 4 or 5 years needing daily care? No one has saved up that much. So we have to get realistic about what we really face. You can get 911 service anywhere in the country and have a pretty good chance that somebody skilled will do resuscitation and try to bring you back. We have most of the population covered for a surgical procedure. But what if you need services for years? What if you need someone to brush your teeth or to spoon feed you or to help you get dressed in the morning so you can get up and around? All of us face that as we grow old. So for a smaller period of time, so it's on the order of 2 to 3 years on average, that we will need daily care. And we've never built that into our planning. So if you ask a dozen people on the street or in your office, how many of you have a plan for how to cover a few years of needing someone's help at the end of life? And people say, you just gotta be kidding, I hope that doesn't happen to me. But if you live to 85 years old, it's really very likely that will happen to you. So it's only if you die young, from cancer or heart disease or something in your 50s, 60s, 70s, that you'll evade the prospect of living with substantial disability. It's just we haven't lived with it long enough. We haven't told the stories. My families still come at frailty and old age as if it's the first time this has happened to anybody. It's completely predictable, but where are the stories? So people don't have the reference points. What does a good family do? What does a good older person do? So we need to tell the stories. We need to build the housing and the nutrition and the sort of daily services. And a piece of it is that we have so overinvested in medical care that you can get the most elegant of drugs, but not someone to wash your face. So it's the wrong set of priorities. If you went out and asked a whole bunch of 88-year-old ladies living alone, what are they most scared of and what do they most need to be sure is in their care system, they'd be the things that are not there. Companionship, food, being sure you're safe. Instead, they can get anything they want in the medical care system, but that often isn't the right stuff. So we need to redesign. We need to redesign so that people can make good choices. I think it's very hard at this point in time, for 20-year-olds to really understand this issue. It's more the 45 and 50-year-olds who are taking care of their parents and starting to see, oh, but I'm next in line. This is a conveyor belt, and I'm next in line, and this is not a system I like. I think that's where sort of the political force could come, is the family caregivers to people who are now old, and who say, how could we have built a system that makes so little sense? Why are there doctors who insist we come to their office? In a suburban or urban area, why don't doctors come to the home when it becomes this hard to get mother out? We have a whole subpopulation of people who only ever get their medical care in the emergency room in the hospital because it is so hard to get them out to the doctor's office. And we don't support doctors coming to the home. And yet you could have a doctor coming to the home for people who are this sick very efficiently, but we don't provide the little bit of extra funding that it would take to move them to the home. So instead, you can call up a $1,000 trip to the hospital in an ambulance and have a $3,000 or $4,000 emergency room run rather than mobilizing some doctors to see people at home. How crazy is this? So the craziness is just all over the place.
I think where a lot of people just are at a loss is everything that you say makes so much sense, but it's like, how do we get there? How do we find ways to fix it?
We have a bunch of ways to fix it, but don't lose the motivation. Even if you don't know exactly how to fix it, just raising your voice is so valuable. It's the complacency of people thinking somehow this is just not a big deal, or it's going to go away, or it isn't going to touch me, that keeps us in the inertia of the present day, where everybody gets up and does tomorrow what they did yesterday. What we need is to get angry enough to demand change, and to be carrying the sign that says it's got to be different, even if you don't know exactly how to change it. But I think that a piece of the change is you've got to have continuity services. A piece of the change is that the care team that is serving this population has to know what it seems to be in the hospital and in the nursing home and at home, how to support a family caregiver, how to find a paid caregiver. You can't have it all broken up in different pieces. A second thing is that every person going through this part of their life needs a real care plan. Somebody needs to have talked with the person going through this piece of their life and their family and said, you know, what are your resources? What are various people willing to do? What's your home like? You know, is it, do you have your own bathroom, or is the bathroom down the hall? You know, is it a shared bathroom? Do you have any way to cook? You know, who can cook for you? Somebody needs to know those sorts of things to put together a care plan that makes sense. It isn't just about medicines and doctor therapies. It's about how you're going to live. And what matters to you? Is what matters to you being able to get out in the park and play chess on a sunny afternoon, or going fishing, or being in touch with your grandchildren, or watching the soaps? And, you know, and the care plan needs to reflect what really is important to this person at this time in their life.
For the people who have not yet become aware or spoken up, what's the case that you would make to them for getting involved and advocating for reform?
Well, first off, there are a lot of people whose the person they're caring for dies or goes into a nursing home and they suddenly have a little more time. Before you forget about it, before you paper it over and make it all make sense, speak up about the challenges that you ran into. The time you were sent out of the hospital and not having any idea what you're supposed to do with the medications. The time you were started on some treatment that required a gizmo of some sort and you had no training in it. The fact that you've been left bankrupt. The biggest cause of personal bankruptcy now in the country is not failed businesses, is serious illness in old age. So speak up about that. We really need our big, state and federal bureaucracy to pay attention. We need the National Institute of Health and AHRQ to be giving grants in this arena. We need Medicare and Medicaid to be trying out new innovations that would serve this population well and at a lower cost. We need there to be attention to the caregivers. Most records in the medical system don't even name the caregiver. There are lots and lots of little things we could do to make this much more possible. And start speaking out in favor of your favorite one. Push your organizations. Push the Alzheimer's Association and the AARP and the whatever other organizations you're in, the Lions Club, the Kiwanis Club, to speak out, to develop an agenda. The women's groups need to be speaking out. The biggest challenge to women now is caregiving to the elderly. We now spend longer time taking care of an older family member than raising children. And yet it's not on the agenda of women's groups? How did this happen? So being a caregiver to an older person is now the biggest challenge that will face most women. And we need to have those groups being, speaking up. Next presidential campaign, congressional campaign, have somebody ready to get in front of the camera on every, local town hall and candidate visit, ready to ask the question, what are we going to do to support aging and disabled people in America? And it's such a solvable issue because we already have the money in the system, at least for the elders. In Medicare and Medicaid and the Older Americans Act, we've already got enough money per capita. We're just using it in all the wrong ways. And that's so much more solvable problem than something that we have not yet tackled and we haven't allocated funds for. So this one we could fix, and then we could go on to the really big things. This one we already are funded. We're already committed, we're already funded. We're just doing it wrong. So let's do the innovations that will get us to where we are doing it right, efficiently, at a price the community can afford, so that the care of older people is not even felt as a drain on the community, but just as a reasonable commitment that each of us make to each other, that you're going to get through to the end of life with some dignity and grace and comfort and meaningfulness, and at a price that we can all afford.
Dr. Lynn, thank you so much for your time. Dr. Joanne Lynn is the director of the Altarum Center for Elder Care and Advanced Illness. Thanks for tuning into the Bioethics channel. I'm Anna Jaffe with the Center for Practical Bioethics.